So in this segment, we're going to discuss one of the most common real-world issues, and that is staphylococcal infections or skin infections. So this is the kind of content that shows up in athletic training rooms and urgent care visits. And sometimes the important question is not just, is this red and infected, but how deep is the infection? How urgent is this infection? And could this be something resistant like MRSA, which we're going to talk about in just a little bit? Staphylococci are gram-positive cocci that classically cluster together. So they often cause skin infections, but they can also go deeper into bone, sinuses, lung, and other tissues. And in a healthy patient, the skin it often contains staph without causing trouble. But if a patient is immunosuppressed, has diabetes, has poor skin integrity, has another condition that weakens defense, staph can become much more problematic. So clinically, one of the first decisions is whether the infection is superficial, like a minor localized skin process, or whether it appears deeper, more invasive, or abscess forming. And that distinction affects the urgency, the referral, and the treatment. And staph infection, if a patient is immunosuppressed, they might be more likely to become infected. And this is also called Staph aureus, and they might be more likely than somebody who is healthy. So other conditions, for instance, a diabetic athlete may be affected differently than someone who is healthy. And that may be due to the nature of the immune system or potential for immunosuppression due to other conditions. As it turns out, diabetics are more likely to experience respiratory infections, skin infections, urinary tract infections, and foot infections. So some of the things that you might see in the field, if we look at skin infection and determine whether it's superficial or deep or more invasive, keeping in context, right, the risk classification and how that might be interpreted. So do not stop at, oh, it's red and infected, but rather let's do a little bit of additional assessment and determine whether resistant staph is a possibility. Again, this may need to be referred out to a physician. So this slide is packed with examples, and the main job here is pattern recognition. So if we're looking at a couple of these, let's take number one, for instance. This is impetigo, and it's highly contagious and often shows a honey-colored crusting, especially around the nose or mouth. Whereas something like number four, furuncle, that's a boil, especially a deeper infected hair follicle. Now, a carbuncle, right next to it, number five, is a cluster of boils. Paresthesia involves the nail fold, while felon is more of a serious fingertip infection, and that's number three. Let's jump over. Let's say, not pictured here, but fasciculitis. That's an inflammation of hair follicles, often bacterial or sometimes fungal. And pictured there, number six, is cellulitis, which is a diffuse skin and soft tissue infection that causes redness, swelling, and pain. Right up at the center of the screen, number two, hidradenitis suppurativa affects apocrine glands, and this is particularly in areas like the axilla or the groin, and it often requires referral. Consider something like anatomy-specific or higher concern sites like blepharitis. This would be something affecting the eyelids, mastitis affecting breast tissue, often in lactating women, but not exclusively. So the teaching point is that staph can show up in many different forms, and we need to learn the visual patterns and the sites where these problems commonly develop. If we take a look again at number one, impetigo, we recognize that, of course, it is a highly contagious skin infection, and it's most common in infants and young kids, and it often is appearing in the face, around the nose, and the mouth. Now, what's going to happen in this case is the sores are going to rupture, they'll ooze for a few days, and then they form that classic yellow-brown crust. And antibiotics may shorten the infection and can also help prevent the spread to others. Another common question might be, can you get strep more than once? Yeah, because there are multiple strains, and this is why you may get sick more than once from the common cold. Now, consider something like cellulitis, which is more bacterial skin infection. Again, it's causing that redness and swelling and pain in the affected area, but cellulitis is a common non-invasive bacterial skin and soft tissue infection. Sometimes it develops from animal bites, surgical sites, sores, burns, diabetic wounds, and many other types of open wounds or broken skin injuries. So these are not too terribly uncommon if not treated and sanitized or cleaned appropriately. So one of the clinical cues, again, is to learn the visual patterns and then ask whether the infection is localized, diffuse, abscess forming, spreading, or located in high-risk areas. So these images reinforce a few high yield points, some additional staphylococcal skin images. Now, blepharitis often reflects an irritated eyelid margin and a clogged small gland, whereas fasciculitis shows staph getting into hair follicles. Bullous impetigo can blister and look pretty dramatic, sometimes even like a burn. Vestibulitis, especially in the central face area, is near the nose. This deserves some respect because the infection in that region raises concern about spread through venous channels and toward deeper structures in the brain. So that's why central facial infections, especially around the nose, should not be brushed off. This slide is also a reminder that visual diagnosis is useful, but location matters just as much as appearance when judging urgency. Take a look at that blepharitis on the screen. This is inflammation of the eyelids, and it can often be hygiene related. Staph infection of the eyelids may become more common in older populations, and blepharitis commonly occurs where tiny oil glands near the base of the eyelashes become clogged, and that causes irritation and redness. Mastitis that we see on the screen is a common occurrence in lactating women, lactation mastitis, in other words, but it could be an issue in non-lactating women due to trauma. Mastitis is an inflammation of the breast tissue that sometimes involves an infection. And the inflammation results in breast pain, swelling, warmth, and redness, and possibly it could be due to blocked milk duct or bacteria that's entered the breast tissue. So it usually occurs within the first 3 months of breastfeeding, and a patient might also have accompanying chills and fever. Let's talk with a little bit more detail on vestibulitis. The vestibule in the house is where you walk in. It's the entryway. Well, vestibulitis here near the nose can be problematic. The concern is that the entry from here enters into the sagittal sinus and cavernous sinus, and that can travel retrograde via the venous circuit, and it makes its way into the brain. So staph in this central portion of the face, the nose primarily, is often emergent. Now, it can work its way back to the brain and result in deeper central nervous system infections, so it should definitely be treated immediately. So this is where we talk about the high yield recognition, but then the location changes the urgency. So keep those things in mind, and we'll use clinical caution where visual diagnosis, supports something, but it doesn't replace clinical judgment and referral decisions. So be conscientious when we are working or seeing some of these staphylococcal skin infections. So here we are, MRSA, commonly referred to as MRSA. This stands for methicillin-resistant Staphylococcus aureus. The key idea is resistance, because antibiotics have been overused or overprescribed for decades, and some organisms have evolved ways to survive medications that used to work. So staph already takes advantage of skin breaks when it gets the chance, and resistant strains make the clinical picture even more difficult. So these images show cellulitic changes or tissue breakdown and a central lesion that should raise suspicion. Now, as a general rule, antibiotic stewardship matters. We do not want to just hand out antibiotics reflexively for every red bump or mild illness. Overprescribing helps keep the resistant problems that we have now, and then we have to manage them later. So the strains resistant to the medication in this case are methicillin or methicillin resistant Staph aureus. So on the cellulitis with necrosis, this of course is an area that has started to have some tissue wear with the necrotic factor. We also see on the screen some cellulitis with a central pinprick of erosion, and there's some notable redness around that lesion. So being mindful that, as we make a decision cued, we don't consider or we should consider MRSA when we're looking at something with drainage, necrosis, a rapid spread, or if an abscess is present. So one of the most memorable teaching points in the staph section, MRSA lesions, are often mistaken for spider bites. This is especially when there is central draining or necrotic area also associated. So if a patient confidently says, hey, I think I was bitten by a spider, I think the first follow-up question is, did you actually see the spider? If the answer is no, well, we're going to keep MRSA on our differential diagnosis. The point is not that spider bites never happen. The point is that a supposed spider bite with the right appearance may really be a bacterial skin infection until proven otherwise. So the moral of the story is that it's oftentimes confused, MRSA is oftentimes confused for a spider bite. Each looks similar, each has a central drainage area. So some people come to the MD and the first question might be, did you see the spider? MRSA infection notoriously has this appearance, so be suspicious of MRSA until proven otherwise. So we're going to drive the previous point home. These lesions were treated with antibiotics because they were infectious, not because they were a true spider bite. And the larger lesson is prevention, better antibiotic judgment by physicians, better hygiene and wound care, and not asking for antibiotics every time someone has a minor illness. These considerations all make a difference in the long run. So as clinicians, as practitioners, one of the primary focus of their job is to resist casually prescribing habits. And that helps resistant organisms to avoid spread. So the key takeaway here is that staph is common, but it's not trivial. Now, if we learn the patterns, we separate superficial problems from invasive ones and stay suspicious of MRSA when a lesion is described, especially if it's described as a spider bite without clear evidence of an actual spider bite. We might be better able to quickly identify a problem and prevent further spread. So we'll learn the patterns, judge urgency, and protect patients with good infection control habits.